So the rationale behind starving the gut seemed to be related to providing functional rest to the GI tract and the pancreas in cases of pancreatitis, for example. But more recently, early enteral nutrition has come into favor. Early enteral nutrition has been demonstrated to improve patient outcomes in cases of parvoviral infection and septic peritonitis, for example. Possible reasons for benefits of nutrition in these cases include reduced endogenous catabolism, improved gut mucosal integrity, reduced bacterial translocation, decreased intestinal inflammation, prevention of protein energy malnutrition, and immune system modulation. It's also important for clinicians to be mindful that many patients who present with acute GI signs, for which you might consider withholding food, have already had decreased food intake before presentation, whether that's partial hyporexia or complete anorexia. And this highlights the importance of gathering a thorough diet history during your patient assessment in order to determine the duration of inadequate food intake, and as such, the urgency with which you feed that patient. So in addition to the effects of malnutrition, which we can see in both dogs and cats, for example, poor wound healing, immunosuppression, increased morbidity and mortality, in anorectic cats, there's an added risk, of course, of development of hepatic lipidosis. And this risk is particularly relevant for your acutely anorexic overweight cats, so we should keep that in mind. In cases of intractable vomiting, regardless of the underlying cause, food can be very briefly withheld, anecdotally for about 24 hours, while the clinician attempts to control vomiting with antiemetic medical therapy. This might be helpful in terms of, say, controlling the patient's ongoing fluid and electrolyte losses through reducing their vomiting, or perhaps even reducing the risk of complications like food aspiration and subsequent pneumonia related to ongoing vomiting and regurgitation. In critically ill or malnourished patients, regardless of the underlying disease process, one reason to delay feeding slightly is to first correct hemodynamic instability or electrolyte derangements before beginning to feed your patient. Well, we can't define specific feeding amounts for all our patients, as this will rely on patient factors like body weight, body condition score, health status, and diet factors like energy density. And while the duration of inappetence should certainly impact the urgency with which you feed a patient, this too should be evaluated in light of the patient's general health status. For example, a healthy 1-year-old patient with a body condition score of 5 out of 9 who presents with acute anorexia may be at a lesser risk of malnutrition than, say, a 14-year-old diabetic patient with decreased body and muscle condition scores. In general, when refeeding patients with prolonged anorexia, and the definition of this is not precisely defined, but some references suggest more than 5 days, or patients with signs of malnutrition, energy delivery should be gradual, starting at about 25 to 33% of the patient's resting energy requirement per day, and increasing by 25 to 33% of RER every 12 to 24 hours until the resting energy requirement is reached per day. While assessing a patient's gastrointestinal tolerance of refeeding, in other words, watching for vomiting, regurgitation, signs of abdominal pain or diarrhea, it may be beneficial to feed the patient small volume meals more frequently. For example, dividing the patient's total daily energy provision over 4 or more meals. This is particularly relevant when relying on assisted enteral feeding or tube feeding, when one has to be quite cognizant of the meal volumes administered. So first and foremost, Consider the patient's medical history and your clinicopathologic data, so your physical examination and diagnostic test results. Do they support a diagnosis of primary gastrointestinal disease or perhaps an extra digestive disease? A comprehensive workup and establishing a diagnosis should largely guide your medical and nutritional recommendations. And in addition to the diagnosis, patient factors that will impact your diet selection include their dietary history, their appetite, body condition score, food preferences, and the owner's feeding preferences. And while there are commonalities among therapeutic gastrointestinal diets like palatability, inclusion of specific fibers, and use of highly digestible ingredients, for example, some key differentiating diet characteristics include the fiber level. So is the diet relatively low in fiber and low residue or highly digestible, or is it fiber enhanced? The fat content, and this is particularly important when managing dogs with certain gastrointestinal conditions, and it also impacts the dietary energy density. And whether or not the diet is formulated with potentially novel or hydrolyzed protein sources.